Hey guys, we're going to go ahead and get finished up with this next small section on your abdomen and KUB. Starting on page 137, we're going to talk about some of the essential projections. And let me toss over real quick. On page 130, you see you got 1, 2, 3, 4, 5. You only have 5 essential views that we need to talk about, so it shouldn't take us quite that long to do it. I am going to share my screen with you in just a little bit, but I want to talk about on page 137 on the AP projection, supine or upright. Talks about your image receptor plate. Obviously, it's going to be a 14 by 17. And if you are able to collimate, you want to collimate from the sides and you want to leave it open top to bottom. So you always want to maybe like 1 inch from this collimated field, 1 inch in, but you always keep it open top to bottom. Position of the patient is the AP abdomen or the KUB projection. Place the patient in either the supine or upright position. The supine position is preferred for most initial examinations of the abdomen. The preferred is standing is the preferred. Your position of the part mid-sagittal plane of the body to the midline of the grid. If the patient is upright, distribute the weight of the body equally on the feet. Place the arms where they do not cast shadows. In other words, get them out of the way. On page 137, it shows you either fold them up high on the chest, or you can, if you're standing up, just have them kind of separate them a little bit away from the actual thorax and the abdomen. I'm going to go ahead and bring this content up for you. Let's see if this is the right one. I think it is. Okay, pretty green. All right, we've covered this already in our previous video talking about the breathing instructions, and you need to really be cognitive that the diaphragm does actually move as we breathe, as we inhale and exhale. So as we take in a deep, deep breath, the diaphragm is actually going down, pushing all the inner visceral organs down tighter in the smaller ball. That makes them harder to distinguish because they're more condensed, they're more compact. As we blow our air out, our diaphragm goes up, and it allows the intestinal loops and all the peritoneal organs to kind of separate. So that's the thing we need to keep in mind when we're doing abdomen / KUBs. It says the diaphragm move positions from upright to the supine, and the highest level of the diaphragm is when you're supine and you're exhaling because it brings it up. The lowest level is when you're standing up, because obviously the weight of all the internal organs in the peritoneum by gravity itself will drop. Usually drops 1.5 to 2 inches down. So here on the page 137 are these images, and we're just going to talk a little bit going back to your book. I'm in the middle column. It says ensure that the weight of the patient is equally distributed when you're doing them supine. Place the arms so they do not cast any shadows. If the patient is supine, as in this picture here, you can see their legs right underneath the knee. There's a sponge that helps relieve the strain off of the back, the lower back, which helps to relax the abdominal muscles and the organs and all. So that's a good thing. I always do it. Make sure you support something underneath the knees. For the supine position, center the IR collimated field at the level of the iliac crest. Again, remember I showed you there's a little soft spot right here, iliac crest, the inferior angle of the ribs. So you're going to put your hand right there, and it's going to cave in, and you're going to feel that curve right there. And in that indentation, you're at L4, or the ala, or the wing of the pelvis. That is L4. That is where your horizontal line will go. Your vertical line will always be MSP, MSP. And here, if it's upright, normally on an upright, if it's for the abdomen to include the diaphragm, you're going to go about 2 inches above the iliac crest. If it's to include the lower portion, to include the bladder, you're going to keep it at the soft spot between the inferior angle of the ribs and the upper portion of the highest curve of the iliac wing. So that again is at L4, MSP. Same thing, PA. You're going to do MSP straight down the spinous processes of the back, the little projections that stick out of the back. Spinous processes come off of the vertebral body. Line it up perfectly there, and again, you're going to find the soft spot, which is going to be at the iliac crest. It says, for the supine iliac crest, ensure that the pubic symphysis is included. So again, looking at this person right here, right there is probably at the base or the upper margin of the pubic symphysis. You can palpate right here on his side, on his hip, and you'll feel the greater trochanter. And when you feel that, that's where you're going to put the bottom of your light to ensure that you get the bladder. You can do the same thing here. You can still palpate there, or you can ask the person, your patient, to press right there, right above the bladder. Everyone knows where the bladder is, and there's a little hard spot, and that is the upper margin of the pubic symphysis, or you can go with the femoral greater trochanter, but you want to include if you're trying to include the bottom of the bladder, you need the upper margin of the pubic symphysis. It says, for the upright position, center the field 2 inches above the iliac crest, high enough to include the diaphragm. So if you're doing this for the diaphragm shot, you're going to go 2 inches above the iliac crest. If you're doing it as if it were a standing KUB, you would be at the iliac crest. So those 2 inches above is going to give you the diaphragm and some of the lower margin of the lung field. So you're going to have to, again, keep in mind what are you shooting for and what is the protocol at these particular facilities. And last bullet there, it says if the bladder is to be included on the upright image, this one right here, the IR collimated field is at the level of the iliac crest. So it becomes this, but just standing. So you do this at the iliac crest to L4. Here's L4 standing if you're going to get the bottom of the pubic symphysis. If you're interested in getting the diaphragm, if this is going to be a diaphragm to include the lower lobes of the lung field, you're going to go 2 inches above. It says if the patient is too tall to include the entire pelvic area, obtain a second image to include the bladder. We'll talk about that. It says it's a 10 by 12, or just if it's DR, you're just going to bring it down. You're going to put this crosshair, you're going to put it 2 inches above the pubic symphysis. It says collimated field is oriented crosswise and is centered 2 to 3 inches above the upper border of the pubic symphysis. So again, guys, if you're not going to get comfortable palpating for that little small pubic symphysis bone, this is medical palpating. We will show you this in clinic how to do it. We will tell the patient what we're going to do. We're going to ask permission if it's okay for us to touch. If not, we can demonstrate on ourselves and ask them to find the little hard spot right below their bladder. Leave their hand there, then you can place your hand below that, and that will give you a landmark. Or again, you can go with the greater trochanter. Different people have different thoughts about this. I'm a medical professional. I palpate. I touch. I warn people I'm going to do it. I've never had a problem in my 30 plus years doing this because I'm a good communicator. I tell exactly what I'm going to be doing. I ask for permission, especially with children. I want them to know what I'm doing. I want the parents to be aware of it, because the worst thing can happen is, the parents aren't in the room with you, and someone goes out, a little child goes out and say, "Mama, that guy touched me down there," or whatever. That's not what happened. So again, we're going to have to use your own I lost my thought here. Transgressions, is that right? Not transgression. Discretion, not transgressions. But anyway, you want to make sure that you're comfortable doing it and that the patient's comfortable allowing you to do it. Respiration, it does say suspend at the end of exhalation so that the abdominal organs are not compressed. So these are done on exhalation, so the diaphragm is going to be pulled up so that you're allowing all of the internal organs not to be so compressed. It does ask you to do gonadal shielding on males. We do it. We should be doing it. It said do it. So try to practice that in your clinical areas. We go to the next ones. It says structure shown. The AP projection of the abdomen shows the size and shape of the liver, the spleen, the kidneys, intra-abdominal calcifications or evidence of tumor masses. Evaluation criteria, evidence of proper collimation. Side marker, upright marker if appropriate, area from the pubic symphysis. There it is right there. To the upper abdomen. 2 images may be necessary if the patient is tall or wide. Center to the vertebral column. You see these little white teardrops? That's the spinous processes. That's the little bumps that you're feeling on the very back of your patient. They should be dead center when you do a good KUB. That's what we look for. We look for this to be dead center, and we're also looking to see the marginal space from the edge of the iliac wing to the outer edge of your film to see if the patient has been centered correctly. There's your SI joints. You want your ala, your wings to be broad and flat. Spinous processes in the center, ischiospines of the pelvis symmetrical. Your ilius is going to be, again, that little crest line right there. You see it? That's what they're after right there. We have equidistance. The ala and wings of the ilia are symmetrical. These are your alas or wings of the pelvis. They should be symmetrical in size. So that was your AP projection, supine or upright. The next one talks about the PA projection. It is very much similar to what we just talked about, but you're doing the PA projection, meaning that you're going to be shooting them from the back. This is when the kidneys are not of interest. If the kidneys are of interest and you're doing a KUB, you should have the kidneys on the table or against the vertical because that's going to give better detail. On page 139, it says when the kidneys are not of primary interest, the upright PA projection should be considered. Compared with the AP projection, the PA projection of the abdomen greatly reduces the gonadal dose. That's the main primary reason we were trying to do on PA. I told you the problem with doing obese patients that's got a little beer gut there. That's going to be a problem because the thorax is going to be further away and your little bellies or big belly is going to be there. So you're going to run into that problem. Position of patient. With the patient in the upright position, place the anterior abdominal surface, contact to the vertical grid, abdominal midline to the midline of the IR. When you're doing it from the back, or you're doing it, you're shooting PA, you're going to run your finger straight down and find those spinous processes. If you're doing it AP, your MSP, you can find the xiphoid tip, the little bouncy part right at the bottom of your sternum, and use that as your guide to find the MSP of the patient from the anterior. Center collimated field 2 inches above the iliac crest. At the level of iliac crest, 2 inches as L3, L1, because this is L4. So if we go 2 inches above, you're going to be about L2, 2, 3. Okay, this is where you're upright. Upright here is talking about this one right here because you're going to be including the diaphragm. Let's see. That's really all they have on that PA versus AP. The next thing we're going to be talking about is your left lateral decubitus position. We've seen that one, left lateral decubitus position. So this turns out to actually look like an AP because look at your tube is going to be horizontal. Your plate is vertical, so you still have that 90-degree angle, but this is now the patient is laying on their side. So this is a left side. We call it side they're lying on. Okay. If the patient is too ill to stand, we want to do the cubed in place of the upright, the lateral recumbent position lying on a radiolucent pad. This does count. The mattress does count. You want to see the little bit of light right here on that bed. That's telling you that you'll be able to see any type of fluid levels down here that accumulate. Let's see. It says a radiolucent pad is particularly important to ensure the inclusion of the entire dependent side when fluid demonstration is a primary concern. I just said that again. You want this side to be raised. The mattress itself works because we have a little bit of light right there, so that little bit of the mattress is actually going to be exposed and we'll be able to see it. Okay, the next thing we talk about, it says if free intraperitoneal air is suspected, have the patient lie on the side for 5 minutes before the exposure to allow air to rise to the highest level in the abdomen. Have the arms above the level of the diaphragm. Just get the arms up and out of the way. Flex the knees slightly to help stabilization. The knees are on top of themselves and flex. Exercise care to ensure that the patient does not fall off the cart or the table or the bed. Make sure if you're doing it on a gurney, on the hospital bed, all the wheels are locked because we do want to keep our patient in this position for a few minutes. Position of the part, adjust the vertical grid to the long axis of the IR centering at the MSP. This is it right here. If the abdomen is too wide to include both flanks, on one image, your flank muscles are right here. They're right on the lateral margin of each side of the abdomen. It says if adjust the patient in the IR height to include side down when intraperitoneal fluid is suspected. You want side down to include side up when a pneumoperitoneum, we mentioned that as free air in the peritoneum, it's going to gravitate up. So you want to make sure that you have this side. Most facilities are going to want you to do one with this side, one to include this side, and an upper and a lower, basically, medial and a lateral. You want to get this side, this lateral side, and this side. So sometimes we'll do it and we'll turn our IR the other way to get both sides. But again, it depends on what you're looking for, whether you're looking for free air or you're looking for fluid. Okay, let's see, position the patient so that the level of the iliac crest is centered to the IR. So again, you're at iliac crest. You can see the soft spot right there. You see this is the curve of the greater wing, the ala. This is the inferior angle right here of the, I don't know why I didn't have my pointer on. Okay, here we go. Right here, you can see that little caved in area right there. So that's the soft spot. That's L4, and we're still at MSP. Central ray is directed horizontal and perpendicular to the midpoint of the IR. Excuse me. All right, structure shown. Let's see if we got an image of that. I think I do. Okay, we got right here, we got size and shape of the liver, spleen, and kidneys. AP abdomen with the patient in the left decubitus position is most valuable when showing free air and air fluid levels when an upright abdomen projection cannot be obtained. So it tells you the AP patient in the left decube position is most valuable for showing free air. So if they're laying on their left side, what big organ is taking up this spot right here? The liver. So your air is going to be able to accumulate quicker because this is a big solid mass right here, and they're on their left side. And you can see just at the margin right here, this little gray area, that's the mattress pad. So you've gotten the iliac wing and all that lifted up, so you're seeing the entire area of the abdomen. These are obviously surgical staples, diaphragm. There's your iliac crest. Okay, and this is on page 140. Diaphragm without motion, both sides of the abdomen. Side down when fluid is suspected. Side down. Side up when free air is suspected. Abdominal walls, flank structures in the diaphragm, no rotation. Spinous process is centered. There's your spinous process is centered right there. See, right there in the middle. Ischial spines of the pelvis symmetrical, if visible. All of the wings symmetrical. So it's the same evaluation that we just read for the actual AP. No, I'm not sick. I'm just coughing, talking too much. All right, on page 141, lateral dorsal decubed. Right and left position. It says turn the patient to the lateral recumbent position. I'm sorry, that's the wrong one. Got that out of shape. Okay, this one here is actually on page 142. Guess we just did the cubes, didn't we? Yeah. All right. So now we're doing the lateral left and right dorsal decubitus. It says when the patient cannot stand or lie on the side of the place the patient in the supine position on a cart or hospital bed support. Suitable support with the right or left side in contact. Again, your mattress will suffice for that. Place the arms above or get them out of the way again. This is very similar to the cube, except the person is now lying flat on their back. Flex the knees to relieve the strain of the back. Exercise care to ensure that the patient does not fall off the wheels. Position of the part, position the patient so that the point approximately 2 inches above the iliac crest is centered. So again, here's your soft spot right there. You can see the kind of the curve right there. So we're a little above it, 2 inches above it. This is going to be at your mid-coronal line here. This is your horizontal line. It's going to be 2 inches above the curve of the iliac crest. Let's see, it says IR is centered at the mid-coronal plane, so that's the line right here. Gonads shield gonads suspend at the end of expiration. I think all of them have been expiration, if I'm thinking right. Collimation field, it says keep your collimation open 14 by 17. It says for smaller patients, collimate to within 1 inch of the anterior up here and your posterior. So you just want to look at this light and collimate it down just a little bit if you can. The lateral projection of the abdomen is valuable in showing the pre-vertebral spaces. Let's see if I got an image of that. Yeah. These are your spaces right here. Vertebral spaces. You notice how all the air, gas filled in the colon, it's gravitated up. You've got a gas level line in the colon. You see how there's a straight line right there? That's an indicator. You got some calcifications here. There's your diaphragm, your posterior ribs. Support. There's your support that the patient's lying on, which would have been the mattress itself. Just make sure if there is something down in that mattress, they need to be lifted up. We have it annotated as a left side up. So this is the left lateral to cubes, letting us know that the left side is touching and that this side it is up. So that will give us our orientation to the image. Let's see, evaluation criteria, proper collimation, marker cleared, clear of anatomy, no rotation, superimposed wings. It's a little underpenetrated here. It's kind of white, but you know, this is all bone down here. There's your L5S1 and your iliac wings. You can barely see them right there, and I can see a little bit of the sacrum and coccyx through that. As much as the remaining abdomen as possible, when the diaphragm is included, abdominal contents visible without contrast. And that is on page 142, guys. We'll look at this. I'm going to show you, I wanted to show you this just to give you an understanding of KUB. Kidneys, ureter, and you see where the bladder is. And again, if you get right there at the upper margin, you'll be able to say that you got the entire bladder. So, and here again, you see this is L3. If we center right there, that's giving us what level? L4, iliac crest, or the ala. That's what it's called. Here's your greater trochanters, right, sticking out right there, right over here. Look what it lines up with, right there. The most prominent knot of it, right there. If you palpate, you're going to hit right there. We're going to cross over and we hit the pubic symphysis. Therefore, you don't really have to touch the patient if you're uncomfortable doing so. This is what we call a tomography, a tomogram. It's blurred image. It's blurred because of a tomographic movement. You don't hardly ever do these anymore, but this is what an injection of a kidney looks like. You see the white and how bright the kidney is. You wouldn't see this without the injection of contrast. So that's what these are used for. This is in the right, that little white line right there. You already have dye coming out of the ureter, flowing out of the ureter, coming down. Remember the filtration of the kidneys, it collects outside first, and then all of it's pulled and comes down the ureters. Let's see what else I got. This is the bladder. So I want to again show you, here's the distal ureters entering the back bottom floor. It goes all the way to the bottom of the bladder. So as the urine is formed, it's pouring out into the bottom of the bladder. This bladder is filled with contrast, but this is in the posterior sides of the bladder is where the ureters connect, and you can see how you can see behind the bladder right there. But here again is your pubic symphysis. If you display just a little bit of that upper margin, you know that you have all of the bladder. If you have to get a bladder, it says 2 to 3 inches from the pubic symphysis. So you'll center right about there. So that's what your image would look like. It'd be about 3 inches above that. So you'd be centered right there, and you'd get this entire obturator foramen. No, what is this? The outlet and inlet of the pelvic right here that holds the bladder. You'd have all that, plus you'd have the bladder in the middle in case you have to throw in an additional bladder shot in with your positioning of the abdomens. I think that's it, guys. Let me stop sharing that content and make sure that there's nothing else I needed to look at. I felt like I skipped something, but I don't know if I did or not. The cubes, we talked about that. We talked about that. Talked about that one. I'm not sure if I talked about the lateral projection on page 141. I don't have a picture for it, but I'm going to go ahead and just give you some of the highlights. It says position again on a 14 by 17, lengthwise turn the patient in a lateral recumbent position on the right or left side. Flex the patient's knees, adjust comfortable. Here you're going to have the mid-coronal plane centered. Support the knees, flex the elbows, and place the hands out of the way. The IR is at the level 2 inches above the iliac crest. Suspend at expiration. Nothing seems to have changed other than the orientation of the tube to the patient. Perpendicular to the IR, 2 inches above the iliac crest. For smaller patients, they do encourage you to collimate. Excuse me. So you basically get the same picture if you do the lateral projection right or left on page 141 as you would if you were doing it in the decubitous. Just think about the orientation of the tube to the patient. It's the same, except you're using a horizontal beam and a vertical device at the for the decubes. Everything else it says the same thing. And under structure shown on page 141 for the lateral projection, the one time that I can remember doing this was when we were doing, the person came in, they had a AAA, which is an abdominal aortic aneurysm. Abdominal aortic aneurysm, the AAA. And that we had to do some dye study in order to see that, and it showed up very, very pretty on this lateral projection. I'm not sure if we did it in a cube or just a lateral projection. But guys, that abdomen and KUBs aren't that hard. I'm a little concerned about the confusion between the two of them, and I think on page 135 it does a great explanation about explaining KUB versus the abdomen. I do want to tell you to turn over on page 132. You need to be familiar with these abbreviations used in the chapter. It's got the AAA, which is abdominal aortic aneurysm. ERCP, you'll hear that again. It's called endoscopic retrograde cholangiopancreatography. NPO, you know that means nothing by mouth. PTC is percutaneous transhepatic cholangiography. And right upper quadrant, you need to know those. You need to start expanding your knowledge and your abbreviations. So when you start doing histories this summer, you'll have some of this, or when you see it, you'll know what it means. Also, summary of pathologies. There's the AAA. There's the ascites, which is just fluid accumulation in the peritoneal cavity. Bowel obstruction, blockage of the bowel lumen. The ileus is paralysis of the intestinal bowel. They call it silent bowel. When you have a major abdominal surgery and they put you to sleep, your bowels actually become paralyzed, and they put you in recovery, and they're waiting for your bowels to wake up. So they say that it's silent bowel. When they listen, they can't hear any gurgling or anything because there's no peristaltic movement in the abdomen. And a lot of times when it turns into what they call an ileus, they can't wake the bowel up, and you end up, of course, the patient's eating and drinking, they start bloating up, and it becomes very, very dangerous because the bowels themselves aren't moving. That the material that you're consuming becomes a major problem. Metastasis, everyone understands what that is. That's cancer moving from one lesion to another part of the body. Pneumoperitoneum, pneumo being air, peritoneum being the abdominal cavity, and obviously tumor. But again, take your time, read this. This is very short. Again, there were only 1, 2, 3, 4, 5 positions that you need to be familiar with. If you have any questions, please let me know. I'll be happy to answer them for you the best I can. And I will be doing probably an image analysis one or image critique on the chest and abdomen sometimes later on. Okay, guys, take care, and I'll see you next time. Thanks.